I just want to see how this is going to work.
What are you doing? You're just fixing your slides?
Yeah, I'm just.
That's Are you picking on me, Carlos? I know. Good morning, everyone, or afternoon. It's 2:00. Sorry, it got me confused. We're just going to go ahead and start the afternoon session. Hopefully people will trickle in through lunch or after lunch. I'm really excited about this session. I think we all spent a lot of time trying to understand, how to attack this this dilemma in surgical training, both good and bad. Robotics has become a disruptive technology, and disruptive not meaning a bad thing, but actually a forward moving thing. The panel originally had 4 speakers. Dr. Carlos Brown, Dr. Tim Nelson, Dr. Bell Alfonso, and Dr. Shireen Tofig. She unfortunately could not be here for personal reasons. So we allow more discussion time, and I've added a few slides to help cover, and she gives her regards as well. I'm just going to go over a few background. Again, I'm talking about robotic surgery today and how it's impacting our surgical training. Nothing to disclose. Robotic assisted surgery has had exponential expansion. We hear it in all of our meetings on the impact, the cost, the ergonomics of it. Since 2014, this paper was published, it's been over 10% per year growth in robotic assisted surgeries. It's found its way into every surgical specialty, even acute care surgery and trauma surgery. It's not uncommon now to see a little bit more robotics integrating into it. Just finding the time to do the robotic is the hard part. It's part of all residency training. Some residencies, their residents are leaving fully robotically trained and not necessarily open training, and then vice versa. Some are still very heavily open training and not enough robotic or minimally invasive training. At the U of A, we had one surgeon who simply joined us and who was a robotic, and immediately numbers just shot off and started competing with OB-GYN. And this is just one surgeon's impact over time in less than a year, you can see. And I can tell you, we just hired our second robotic trained acute care surgeon, and I think we've done like 7 cases in the last month that we probably would have done laparoscopically and struggled with, that the robot actually made sense to. But what does all that mean? We're not sure. There's supposed advantages to robotic assisted surgery, including mechanical and ergonomic improvements for the surgeon. The benefits must be balanced against the training burden that we're all encountering in 2022. General surgery residency has really trained over the last 2 decades, changed up over the last 2 decades. There's a decline in overall resident cases. What does that mean? The 8-hour work week, not that it's good or bad, but rather it just sets a different time period and amount of time that residents can actually train. And how do we balance all that? And, I'm not going to go into details. I'm gonna leave it to the speakers, but there's, surveys. This is almost a 10-year-old study looking at program directors from across the country. Just there's concerns about inadequately prepared general surgery resident training. And these are from the people that are training them. And then if you look at what they're talking about, unprepared for the OR, cannot independently perform laparoscopic surgeries and some things, unable to be unsupervised. I think this is data that our program directors are putting there. And then if you look at, 56% felt that the residents could not laparoscopically suture. And now we're moved into this robotic era. And so we're diluting that experience even more. And I think it's critical to understand that. And so really it comes down to balancing exposure to open laparoscopic and robotic platforms. I think that's really what we want to get to. And we ask some of our experts to come up here and help us kind of understand how to go about attacking this issue. These are the lectures for today. I'm just going to introduce each speaker as they come up, and we're going to leave ample amount of time for discussion at the end of all 3 lectures. I would ask that you just save your questions. Our first presenter is, what does your new general surgery partner look like? And the nidus behind this is really, who are we hiring into our surgical practices in 2022? And Dr. Brown is the chief of division of acute care surgery and a professor in the Department of Surgery at the University of Austin in Texas, who's going to talk to us about this subject. Carlos, thank you.
All right, thanks, Bilal, and thanks to you and your program committee for getting this important topic on the agenda. So I'm going to talk to you today about what your new general surgery partner looks like. I don't have any financial disclosures. I do disclose that I do not use robotic surgery in my practice at all, so I may be slightly biased. Obviously, my residents do use quite a bit of it. So objectives today are talk about the current requirements for general surgery residents, recent changes in operative experience for our residents, and what the impact of robotics has been for general surgery training. So obviously, all your graduates are going to come out with the check boxes that are required currently to finish residency: FLS, FES, ACLS, and ATLS. But I want to spend a little bit of time on the index cases. And I'm sure those of you that are program directors or heavily involved on the side of surgical education have seen this list over and over again. But even though as a program director, I see this list and review it twice a year with each of my residents, what their numbers look like. It was interesting to drill down on this list for this presentation. So we'll start from the bottom. The bottom tells you the total major cases, 850. Chief year major cases and TA cases. And this 850 is actually up recently from 750, and the chief year major cases is up as well. And then a teaching assistant case requirement, and the chief case and the TA case cannot overlap. So those are distinct cases the resident has to perform. When you see these numbers, though, I think it's important to consider certain things. One is double counting. Double counting can significantly change the resident's actual experience to what your perception of their experience is if you just review their case log. For example, double counting, so E-codes, exposure codes. So one resident can expose a vascular repair and the other can actually do the repair. If there's a surgeon, junior, and a TA, they can each take components of the case. You can have a junior resident do a component of a case and a senior resident do a component of a case, and they can both count it. So there's some of that. But then there's actual cases that one resident can do, a lap appy, a lap chole, and head and neck cases that they can double count. So an appy will count as a laparoscopic case and a GI alimentary case. A chole, same thing as a laparoscopic case and a biliary case. And then head and neck has a lot of overlap. All the thyroid, parathyroid cases count as endocrine cases, and then also count as head and neck cases. Carotid cases count as a head and neck case and a vascular case. And so there's double counting there that can sort of put some gray to what seems to be a black and white situation. Similarly, there's undercounting. Cases that residents really want to brag about, like a Whipple, they're going to make sure they count every single one so they can graduate and say, I did 17 Whipples or 50 Whipples. But when they hit their critical care numbers or their trauma numbers, they may just stop right there. When they hit their 75th or 85th endoscopy, they may stop counting. So the residents that stop counting cases, so their numbers also may not be represented due to undercounting during their time. There's a whole slew of non-defined category cases. So these are all the defined category ones, but there's non-defined category cases that the residents get hundreds and hundreds of that are not represented in this total major cases. And then robotics don't appear anywhere in the defined categories, right? There's no requirement to have any robotic experience whatsoever in residency training. And there's no way to distinguish a robotic versus a laparoscopic, cholecystectomy, appendectomy, hernia repair, and so on. So something to consider when you're looking at these cases. The other relatively new requirement is you have to have 250 cases by the end of your second year to make sure that we get early operative experience for our trainees. Now break this down a little bit more. Skin, soft tissue, and breast, they get plenty of experience with this. And I'm going to sort of go off the assumption the resident's going to graduate with the bare minimum cases for each category. So skin, soft tissue, and breast, the residents are going to get quite a bit. However, if you look closely, though, only 5 axillary dissections and only 5 mastectomies. Now, obviously, that's a much more minimally invasive approach to breast cancer surgery now, but realize just the bare minimum, they may not have a depth of experience or breadth of experience in those more complex operations. Head and neck and endocrine. So I mentioned these are overlaps. So these 15 endocrine cases of thyroid, parathyroid could also count for head and neck cases. So they're not cumulative, right? These are in the same category. So you may get a little bit of a skewed view of what their actual experience is. As you would expect, huge number of alimentary tract cases and abdominal cases, obviously for a general surgeon, right? So they get a ton of stomach, small bowel, large bowel, appendix, anorectal, and then 85 biliary cases and 85 hernia cases. So the bare minimums here are more than enough for somebody to graduate and go into independent practice as a general surgeon. However, 2 areas, the alimentary tract and the abdominal tract are 3 areas, excuse me, the esophagus, 5 cases, liver, 5, and pancreas, 5. So if a resident meets the bare minimum for these requirements, you can't imagine they're going to be proficient doing these operations when they join your practice. It's just not a realistic expectation. Now, sure, some residents may have 40, 50, 60 esophageal cases or the same for livers or Whipples, depending where they train. But having the bare minimum is probably not going to prepare you to be practicing in these areas. Vascular has taken a huge tumble. Only 10 open anastomosis repair or endarterectomy cases required to graduate, and only 5 thoracotomies. So your resident that graduates is not going to be skilled in most likely, if they meet the bare minimums, not going to be skilled in open vascular surgery or thoracic surgery. Operative trauma I mentioned earlier in critical care. These numbers, at least in my experience, a lot of these numbers will just be filled in towards the end of their residency when they're about to graduate. They get all their non-op traumas, their critical cares, they fill in to make sure they meet the minimum requirements, and they turn in their paperwork to the board. Not ideal, and may not truly represent what they're actually doing. Plenty of laparoscopic cases, both basic and complex. And then endoscopy numbers have gone up significantly with 35 upper and 50 lower endoscopy. So the laparoscopic endoscopic experiences have increased significantly, and this is reflected in the case minimums. So if you look overall, what our general surgery graduate looks like, it looks like a bread and butter general surgeon. After Dr. Brazel's talk, I sort of just put a spork up here instead of the bread and butter because it would have made more sense now. I didn't know that was going to be the talk, though. Sorry, I missed that opportunity. But they're doing bread and butter general surgery. So the residents that graduate today should be comfortable doing bread and butter, skin, breast, alimentary tract, abdomen, basic and complex laparoscopy. I think that's great. We're going to produce well-rounded general surgeons to go into practice and do general surgery. But expect them to do open vascular, thoracic, pancreatic, liver, meaning the bare minimum. I think that's probably a bit of a reach. Some areas of concern, head and neck with that overlap with endocrine cases, not really sure how much experience they may have. Again, operative, non-operative trauma and surgical critical care, it's unclear how they're really counting those and what experience they actually have. That needs to be a kind of a more detailed conversation. And where are the real problems in our training right now? I mentioned esophagus, liver, pancreas, vascular, and thoracic. The bare minimums are literally just bare minimums, like an exposure for that resident to make sure they have some exposure to that to say, okay, do I want to train in this fellowship? Do I want this as part of my practice or not? But probably not going to graduate independently ready to do these operations. So what about changes? What about recent changes to operative experience? So there's a paper in 2021, a 20-year review of surgical training case logs, and see if general surgery is still general. This was an ACGME case log statistics report analysis comparing 1999 to 2019. They actually had 10% more cases, almost 11% more cases during that time period change. And what has gone up? Total major cases gone up. And again, the general surgery bread and butter has gone up. Abdomen, alimentary, skin and soft tissues, endocrine, head and neck, again, those are double counted, and then transplant would make sense as well. And what's gone down? What we talked about, thoracic, breast, trauma, operative cases for sure have gone down. Pediatric and vascular has gone down by far the most of all the cases. So a really different looking graduate today versus 20 years ago. Another study here, single institution ACGME case logs of 101 graduates, and they analyzed by fellowship choice. So what fellowship they were going into was driving what cases they were doing, which makes perfect sense. So people going to endocrine fellowships, we're doing more endocrine surgery. If you're going into thoracic, you're doing more thoracic and less MIS and bariatric. Similarly, you go into vascular, you're gonna fill your case log with vascular cases. You go into trauma, fill it with trauma. Endoscopy, you're gonna fill it with endoscopic cases if you're going to general surgery specialties. And then if you're doing breast, no real difference, except you're going to do much less vascular surgery than if you're doing another fellowship. So they're sort of self-selecting and self-specializing in their residency program based on what they like and what they want to do in practice. So what about robotics? What about the impact of robotics on our general surgery trainees? So this study, retrospective study, 2011 to 2015, looking at laparoscopic or robotic cholecystectomy, ventral hernia, inguinal hernia. Far more laparoscopic cases, 2260 versus 139 robotic cases, and they compared these two groups. So what you see, as you would make sense, the red line is the laparoscopic cases going down, the blue line is robotic cases going up immediately when they introduced this in the second half of 2013. And this is, I think, a good study to look at if you're starting a robotics program. So if you're starting out and your attendings are still on the learning curve, the cases where the resident was scrubbed was only 69%. That means there's residents just weren't scrubbing at all for some of these cases early on. Residents at the console for any part of the procedure, 21%. Meaning they were doing the docking stuff and the basic stuff at the bedside, but not at the console. And then residents spending greater than 50% of the procedure at the console, only 18%. I think in a mature robotics program, these numbers change significantly, but if you're just starting a robotics program, your residents are gonna lose the opportunity to do that operation and count that operation in their defined categories. Similarly, what are the residents' views of the impact of robotic surgery? This is a single institution, 24 currently enrolled residents, and they looked at case logs and they surveyed the residents. If you look at robotic in red, laparoscopic in black, and open in gray, you can see the robotic cases in 2013 were kind of minimal, and then 14, 15, 16, 17, you got more and more robotic cases and less open cases as time went on. And then asking the residents, overall, did the residents think robotics was beneficial? Overall, over half the residents did. This was very much weighted by the junior residents. The junior residents thought it was beneficial, but if you look at the senior residents on the far right, far fewer thought it was beneficial, and some actually thought it was not beneficial to have the robotic experience. And does it impede education overall? Yes, about 30% thought yes, but again, this was based on junior versus senior. The junior residents did not think it impeded education at all, whereas the senior residents thought it impeded education significantly. So the residents are going to have opinions about the impact of robotics on their training as well. And then this is an interesting study just from this year, a single institution, 2014 to 2020, 77 resident case logs, looked at 35,000 cases. And if you look, this is a cool study, because if you see over time, from the time robotics got started in 1617 to 1920, the robotic cases went up significantly every single year. But the cool thing about this is the overall open and laparoscopic cases did not change. If you're going to introduce robotics into your residency, this is the way to do it. Don't limit their laparoscopic and open experience at the expense of robotics, right? So try to introduce as an additive operative experience. And then finally, what do the program directors think about robotic surgery and how it should look like in the future? This was program directors in the APDS listserv. And there was a bunch of questions that I'll go through one by one here. So should the residents be operating at the console? Almost everybody would say yes. Bedside assisting, 75% agree. Robotics certification, 66% agree. FLS for robotics, about half. Does it have a negative impact? Yes. 2/3 of the program directors think the robotics has a negative impact on general surgery training. However, the net overall benefit, 83% think it's a net overall benefit to have robotics in training. So in conclusion, the current requirements are producing great bread and butter general surgeons that we need in practice. We need to have out in the community at academic centers doing bread and butter general surgery. And I think that's fantastic. But to think that they're going to graduate ready to do vascular, thoracic, liver, and pancreas is probably unrealistic in today's day and age. The recent changes in operative experience have been fairly significant, kind of reflecting what we're producing now. And the impact of robotics is real. I think it's to be determined if it's a positive impact or a negative impact, and how to incorporate it with open and laparoscopic surgery. Thank you.
Excellent, Dr. Brown, as always. Our next speaker is Dr. Timothy Nelson, Chair of Surgery at OU Tulsa School of Community Medicine in Oklahoma. And he's going to be talking to us about, should the ABS and ACGME set training standards on robotic surgery training?
All right, thanks. It's great to be here and to talk about this particular topic. So I don't have any financial disclosures. I am a counselor at the American Board of Surgery and was recently the chair of the General Surgery Board. So I do have some inside knowledge there, but they don't pay me anything for that. So no disclosures. I like these superhero TV shows and movies. I grew up as a big fan of Batman, and Batman was really cool because he had a utility belt and he had all kinds of magical toys. And I like Wonder Woman. She could do magical things because she has these golden lasso and an invisible airplane and things on her wrist that could deflect bullets. And Iron Man, and he just a normal guy, and he gets in this suit and he's fantastic. And I remember the old Batman show. Whenever I'm in the OR, I always think of this quote from Batman. The Joker says, "Where does he get those wonderful toys?" Well, I think there's another superhero, and that's all of us surgeons. I think we're able to really do superhero stuff, but we have wonderful toys also that help us to do that. It's anything from basic surgical instruments to laparoscopic equipment, to endovascular equipment, CTs. And yes, it also includes the robot. I mean, I think it is one of those wonderful toys that allows us to be superheroes to our patients. So at the end of this couple of minutes, I hope that you'll be able to describe the approach of the American Board of Surgery towards robotic procedures in both training and practice, and also describe the requirements of the ACGME around robotic surgery, and then answer for yourself the question of should the ABS and the ACGME regulate the training of these. So I went to the ABS website, and these are things that I help actually refine and make sure up to date and edit. And I got this thing, the booklet of information. This is where it tells you what it you need to do to be a general surgeon, both to be in practice and then in continuing practice. This is the rules. And I searched this document for the word robot or robotics or anything like that, and it came up exactly 0 times. So nowhere in this document is the word robot or robotics used. It does have some of these things, and sorry for my very poor way of doing this, but this is some of the same stuff I show that you saw Dr. Brown show about training requirements. And just to be clear, he showed all those detailed requirements about what it takes to be a surgeon. Those are not the requirements of the American Board of Surgery. Those are the requirements of the review committee of the ACGME. Those are the requirements of what a program has to give their residents. It's not a requirement actually of what it takes to be a board certified surgeon. What it takes to be a board certified surgeon, when your residents send those papers in, this is what's looked for. Do they have 850 cases total? Do they have 200 cases their chief year? Do they have at least 25 documented teaching assistant cases? And then earlier on there, and then do they have the 40 critical care cases that they've done? That's what's looked at. And it's true that there is a new requirement in order to actually a slight different, not to finish your PG 2 year, but to start your PG 3 year, you have to have 250 cases. So that's an internal check. And the reason that was done just to make sure that in our training, people were getting in the operating room early. So this is actually what's required by the American Board of Surgery. However, there is the Surgical Council on Resident Education. This is the curricular documents. This is an organization that's wholly owned now by the American Board of Surgery. These are the curricular documents for what it means to be a general surgeon. And within this document, you can search and robotics comes up exactly 1 time. It's under medical information, medical knowledge. Number 7 includes robotic surgery principles. So that is the area where it discusses the fact that it is actually a requirement to understand the principles of robotic surgery. That is an expectation of the curriculum, but it's not something that's checked at the end of your time. We were tasked as counselors of the American Board of Surgery. I'm on a committee called the Education Training Committee. We were tasked with answering this question by our board, our governing board, about could we look at robotics because it's this new technology that is changing the way we do things. And can we come up with a statement about what robotics is and what it needs to be? And what we came out was this statement, that it's not a discipline on its own, rather that it's an enabling technology. And that knowledge in robotic surgery is a training requirement, and therefore knowledge and skill in robotic surgery can and should be assessed in the in-training exam, qualifying exam, that's the written exam, the certifying exam, that's the oral exam, or even the continuous certification examination as deemed appropriate by each subspecialty board. So that means the general surgery board, that means the critical care board, pediatric board, complex general surgery oncology board, the vascular board. I think I got them all. So all of those can include these as part of it. So that is the requirements. That's how we understand it, that this is an enabling technology. It is not something wholly different and new, but it's just part of the way we do business. The ACGME is a different organization. So the American Board of Surgery looks at individual surgeons, both diplomats and those in trainee, and the ACGME looks at the programs through its review committee, surgery review committee. And I feel bad saying something up here. I hope that our president will get up and make a comment sometime, since she's a member of the review committee and I think could speak better about how they think from the inside. But I did look at their document. You can look online, you can get the program requirements for graduate medical education and general surgery, and you can search that document for robotic cases, and you won't see the word robot come up once, at least not with my technology. It's not in there. What is new, and I understand I talked to Dr. Mary Killian-Smith, who's vice president of ACGME. She oversees all the procedural specialties. So how I understand her job is new is it is now, you are now able as a resident, when you log a case, there is, as you can see, an additional area to check. It's over there on the left side where it says robotic. So if you're doing a case and it's robotic, you can now, I believe as of July 1st of this year, they can now log that as robotic. That is new. The urology residents have had that for several years. I think the general surgery residents are the next ones who've got it. And I think there are plans for the gynecologic residents to also get that in the future. This is the only place, as I understand it, where the ACGME has knowledge of whether a case is done robotically or not. So I think that answers not the question you asked me, but really what are we doing now as the American Board of Surgery and the ACGME to regulate robotic surgery? We don't really do it specifically. It's understood. It is one of the enabling technologies. It's something you need to know how to do. It's something you need to know about, but you don't necessarily have to do it in practice, but you are required to know about it. So this was just an opportunity to show off my granddaughter, Noella, who's 11 months old and who's adorable. So, and also remember that I'm going to go to a new topic where now you're going to hear Tim Nelson's opinion because I want to answer the question of should. And the question of should is really, it's a value statement. So I'm going to give you what I think, and then I hope from that you're going to determine at the end of this panel what you think. So should the ABS and ACGME set training standards for robotic surgery training? And I think it depends. One of the things, there's three things that I think about a lot of this. And one of them is the fact that I was a program director for a lot of years. Some of my friends in the room are or were program directors. And one of the things about being a program director is a lot of requirements. And it just feels like things are just getting overstuffed and more is getting added on. And if you keep adding stuff on and you don't take something away, eventually you're going to have a problem or you're going to have a crash. So I think that there is a basic principle that we shouldn't add stuff on unless we're willing to take stuff away because the curriculum is already packed. So my opinion is we shouldn't add things on unless we're going to take something away. So if we're going to add on a specific required curriculum around robotic surgery, I think we have to say what can go away. And I don't think we're ready right now for something else to go away. So until we can answer that question, I don't think we should add a specific requirement for a robotic surgery. Another question that comes up, and we actually addressed in our paper, is the fact that functionally, there's really only one company right now when you're talking about intra-abdominal laparoscopic robotic surgery. There's really one player. And if the American Board of Surgery or the ACGME, I think, were to endorse a requirement to train functionally, the American Board of Surgery would be endorsing a specific company with a specific product. And I think that just doesn't quite sit right with me, at least. It seems like it's not quite the right thing to do, and we're not really there yet. So I don't think that endorsing a specific curriculum around one specific company's technology is the right thing for the American Board of Surgery to do. And I would guess the ACGME would feel the same way. And the final consideration that I have is we are in the process, and the American Board of Surgery is leading this charge, but the ACGME is and a lot of other groups are on board with helping us of redesigning a competency-based education and doing that using trustable professional activities. And everyone who's a program director knows is starting to know these words of the EPAs. And it's a new way of breaking down the things we do as surgeons and actually breaking them into units and saying, can someone take care of someone with right lower quadrant pain? Are they entrustable? If you have a resident, are they entrustable to see this patient? I sort of think of it as if a chief resident calls me and I'm at home and they say, Dr. Nelson, I've got someone with right lower quadrant pain. They got a CT scan that shows this. I think it's appendicitis. I think we should take them to the OR. I'll say, okay, call the OR, tell them I'm on my way in. Let's go up. If an intern calls and tells me a similar story, I'm going to say, okay, what bay are they in? I'm going to meet you in the emergency room because I'm not ready yet to entrust with them with the decision to go to the OR, but with my chief residents. And it's somewhere in between there. Third years, I'm probably comfortable also. And actually, maybe it depends on the third year. Maybe some third years I'm more comfortable than others. I can entrust them with those decisions. Some chief residents, I can entrust them to do the operation where I don't need to scrub in. Others, I need to do the operation and be scrubbed with them if it's a first year resident. So there's this line of entrustability. And I think that this may answer this is a new thing that we're adding in. And there may be an ability within these entrustable professional activities, I think, to create some sort of moderation, since a lot of these things are going to be done robotically. These operations are being done more and more robotically. I think there's going to be some ability with these entrustable professional activities to actually functionally set that up. Another thing that I don't have a slide for, but I think it just goes along with adding stuff up, is I just have a lot of faith in our faculty and our program directors that they know that they need to teach residents how to do these laparoscopic these robotic procedures, and that they can set up the curriculum, and they have the curriculum out there and they can institute it. And I don't think they need the American Board of Surgery telling them exactly how to do it. That's Tim Nelson's opinion. I think they can do it better on their own. So anyhow, in summary, robotic surgery is an enabling technology. Medical knowledge of robotic surgery, however, is required by the ABS, and should specific training requirements be mandated by the American Board of Surgery, Tim Nelson thinks they should not be, at least for now. So thank you. And I guess we'll do questions at the end.
Thanks, Dr. Nelson. Our next speaker is on how to maintain open surgical skills in the robotic era is Dr. Infonsum, who was a program director at the University of Arizona with us and now the chair of surgery at LSU. I'm going to read a little bit of your bio, which needs to be updated, but it says, Dr. Fonsum is one of just a few surgeons in the nation using minimally invasive techniques for colon and rectal surgery, such as advanced laparoscopy, single incision surgery, and robotic surgery, which have been shown to reduce the patient's wound infection rate. I think the point to reading it really is robotics is, you have to be part of it for our patients. And so I think Val talking to us about the other side of the fence here will be really important to understand this. Thanks, Dr. Fonsum.
All right, thank you. Thank you for this opportunity. I'm just gonna talk about maintaining opening surgical skills in this era of robotic surgery. I actually have nothing to disclose. So, as the previous speaker actually said, over the last several decades, there have been a significant increase in the adoption of the robot in a wide variety of surgical procedures. And this has actually not normally been the case over several decades. We actually saw the adoption of laparoscopy, and that actually took a while for certain surgeons to do. But interestingly, the early adopters of the robot were actually gynecologists. And, they actually made a transition from going from open surgery straight to the robot. So in between, a lot of gynecologists that actually skipped a laparoscopy. And then we saw the adoption of the robot by urologists for obvious reasons. They actually talk about how important it is, or how the outcome from prostatectomy using the robot was more efficient to use the robot, and the outcomes were better. But in the last, I would say, the last decade, the largest and the fastest growth in the use of the robot was seen in general surgery. So back in 2020, in this study coming out from Michigan, again, clearly shows that there has been a significant increase in the use of a robot in general surgery procedures. And this Michigan cooperative study involving 73 hospitals in Michigan, in addition, showed that as we saw a significant increase in the use of the robot, we actually saw a decline in the use in open surgery, and also in laparoscopy. But the highest increase in the use of the robot was actually seen in ventral hernias and inguinal hernias, which is not surprising. Now we're seeing a fair amount of cholecystectomies done using the robot. In that same study, you see that the hospitals that actually adopted robotic surgery saw a kind of decline in laparoscopic surgery and also in open surgery. Meanwhile, robotic surgery just kept taking off. So over this course of several years now, there are multiple studies that have shown that the outcomes of robotic surgery is actually better. And that's the reason why we have this significant push to adopt robotic surgery. And these outcomes include length of stay, which is a reduction of the length of stay. In addition, there's also a decrease in SSI. As you guys know, hospitals actually push significantly on reduction of SSI. There's also early return to work, and the robot actually offers a better ergonomics, and you can, and especially when you do ventral hernia repairs, and also when you're down in the pelvis. I would say the robot, the adoption or the use of the robot is also driven by patients. There's patient satisfaction. And when your patients normally ask you if you're going to use the robot for the operation, and this also might be driven by social pressures and perceptions. I would also echo what Dr. Nelson mentioned, how industry is putting pressure on the use of the robot. And intuitive, in particular, we all know how much pressure it pushes on people and hospitals to adopt the use of the robot. In some other cases, it's obvious that exposure is better when you use the robot, and you see this in pelvic surgery, especially in when you're dealing with rectal cancers or dissecting in the pelvis and prostatectomies, and also in some GYN cases. And so the robot is actually has an advantage in that you can see better, there's a better way to maneuver around that tight space. However, data supporting the use of the robot is not always great. So there's limited evidence to show that is in use in every case. Some randomized controlled trials have actually shown benefits, showed no benefits in the robot in rectal cancer surgery. And this is a recent publication. And there are also potential worse outcomes seen in cervical cancer. Another study showed that. There's significant cost in using the robot, and still, despite all this not so great stuff, there's still significant increase in the adoption and use of the robot. And so there is consequence when you, as we adopt the use of the robot. There is a definite decrease in number of open cases, and there's also significant skills decay. So when there's less cases, that means that the residents are less exposed to open procedures. And then people who trained in the past and then not being able to do these cases repeatedly, they end up with skills decay. A lot of studies that have shown that if you stop doing an operation for more than a year, your skills actually depreciate. So again, if we're not training our residents to do this, open cases, they would not have opportunity to train to do it. And people who have been trained before and not being able to do these cases will end up with skills decay. All right, so when I think of skills decay and also lack of open skills acquisition, I think of what Malcolm Gladwell actually said in his book Outliers about a 10,000 hour rule to acquire proficiency. The next generation of surgical trainees able to get their 10,000 hours of open surgery? I don't know. We will see when that time comes. So again, clearly these very well accomplished artists and sportsmen put their 10,000 hours to be able to get to the top of their game. But I was also intrigued by Erickson, who stated that nobody actually becomes an outstanding professional without experience. But extensive experience does not invariably lead people to become experts. And so do we really need 10,000 hours for open surgery to be proficient? Again, I really don't know, but I don't think so. So I think that as the open cases get less and less, we should actually shift the training paradigm for open surgery. And also the way we retrain ourselves to avoid skills decay. We should be more deliberate and more targeted in the training and maintenance of open surgical skills. So we can't use the same paradigm that we used to train people 20, 30 years ago in this day and age, especially as the open cases become fewer and fewer. So why do we need to maintain open surgical skills? So the reason for this are multiple. So we continue to make significant advances in in the use of the robot, but I still think that open surgical skills are still very warranted. There are cases that are still not amenable to robotic surgery due to the operational platform not being available or just prohibitive cost. That just doesn't make sense. There are times when even using the robot, one has to convert to an open procedure, and this it's important that if you don't know how to do an open procedure, then that would be a big problem. There are also no benefit of using the robot in certain cases. And so it's important to learn how to do these cases open. Emergency cases, I think, is one of the major reasons why we need to continue to maintain open surgical skills. This is important for critical exposure and also transplant procurements also mostly done open in this day and age, even though it can be done in a minimally invasive way. Keep moving. So there's no doubt that some open procedures will just go away. There's less and less opportunity to train new providers, and also there's less opportunity to train previous surgeons, and leading to skills decay. So, like Erickson said, we should be more deliberate and more targeted in the training and maintenance of open surgical skills. And we should change our training paradigm to be more to be sure that there is deliberate teaching when we have an opportunity to teach our trainees with the dwindling open procedures. We should also adopt a video-based learning. The ACS is driving this initiative. Unfortunately, most of the video-based training is MIS videos. Trainees should definitely review videos before cases, and should be used as a refresher for people who have also been trained in the past. Video-based learning is not new. This is how chess players use these techniques to improve their game. And one of the things we should also think about is that simulation and cadaver labs are critical in maintaining open techniques. I don't think that there's enough done by general surgeons, enough cadaver labs, but there's more utilization of these cadaver labs and simulation done by other specialties. Think of plastic surgery, vascular surgeons use more cadaver labs than we're doing in general surgery. There should be more general surgeons using cadaver labs and simulation in the training, and also preventing of skills decay. Transplant organ procurement could also be used. So a lot of this is still done open, so trainees could actually benefit from this. This has an advantage of good exposure and also better anatomy appreciation. And so in conclusion, I think robotic surgery is becoming more prevalent. Opportunities to do open cases are getting less and less. And I think it's time for us to think training paradigm for teaching our trainees on how to do open operations. If not, the consequences will be further down the road. Thank you.
We're going to actually open up the session to questions, because there's only about 12 minutes left. But as people are making their way forward, I want to bring up two questions myself. Carlos, so case logs that currently exist. In 2022, I had a partner the other day, like, oh, I did all my lysis of adhesions with a robot. But on paper, it looks like those core procedures that you showed are still being done open. But what happens when a training program is doing all of those cases with robots? You can't tell that, is that right?
No, so I review the case logs with the residents twice a year at their evaluation, and I actually have not brought this up, how much of this, these small bowel cases are open or laparoscopic or robotic. I don't really have a way to tell that. Tim brought up the new way you can now log your case as a robotic case. That's a pretty new phenomenon. So there's no way to look at a case log and see what's open, what's laparoscopic, what's robotic. I know from my own program, they get a pretty good mix of all three, but you're right, there's no way to do that. But that might be something to incorporate in those midterm evaluations, especially for the senior residents. I see you've done 100 small bowel cases, or have them documented some other way so you can see what components of their training are open, laparoscopic or robotic.
And then one other question is, we're environmentally stuck where we are, right? Like wherever you're training, that's what how many, I just want to survey the room. How many programs out there or faculty work in programs where you do shared training, meaning your residents go to another program for 6 months a year to do heavy robotics, or they come to your program to do heavy open surgery? Does that exist? Is anyone doing that? Not your own residency or hospitals in your residency, outside your hospital. I see 2 hands out there for robotic training and whatnot. Awesome. All right, we'll just go to the audience.
Sabaganai, UND. Thank you for your discussion. A lot of what was discussed was actually numbers of cases and the complement of what's in our training programs. But I wanted to kind of go into the quality of how we train robotics versus the other disciplines, because open and laparoscopic does have a sort of nuanced stance of control and autonomy, where you can give and take as you go along the case, as you are learning with new trainees in particular. Robot, when we're talking about the dual console, you do have to shift that, but pass the baton. And it relies on 2 different ways. One, in terms of how you communicate in the OR, and also how you partition a case in terms of whether you give the whole component of an operation versus break it down. And so I wondered if there was any more discussion in terms of how we change or how we teach.
Dr. Nelson.
I think that's one of the ways that there's this potential for the entrustable professional activities to actually be a competency. That's what I'm kind of hearing, is it's more of a competency based question, is how do you know someone hasn't just done them, but they're actually competent to do them, or competent at what level? So I don't know exactly how the EPAs are going to play out. Our president knows a lot about the EPAs, so she may have some comments here too, but I don't know if that's going to be something that we find gets incorporated into that, or if we're going to do a different way of doing that. But I do think this concept, are they safe to operate robotically? Because you know what, that's what the hospitals want to know. It's no longer, when I finished training, I had a golden ticket. If it said ABS, even eligible, it didn't say I could do anything. Now that's not enough. Our hospitals want to know, what's the evidence that you're competent to do these procedures? So I think that's a question we're gonna have to answer.
And just to talk about the console, I always hear about the console. I mean, technology and virtual training, whether it be the Oculus or the Microsoft Lens, is out there, and we've never really adopted it to programming open surgeries in a virtual manner. And I think if you look at what the military is doing in some training programs, there's a lot of work being done and simulation where it's just kind of the same thing, where everyone's in the same room operating virtually. And how do you transition that ability to the next player or the next surgeon? And I
think the communication that goes between the primary surgeon and the trainee is more like simulation.
Yeah.
In the sense of you have it. So it's a little bit different how we operate open compared to robotic.
But I think some of that has to do with the culture of your program, right? If your culture of your program provides autonomy to the residents, open or laparoscopic, they're likely to provide the same autonomy robotically, though the handover is a little bit different. And as an individual surgeon, how does that surgeon deal with open laparoscopic cases? It's probably going to be the same with robotic. If someone has tendency to provide more, at least in my group, more autonomy a surgeon gives, it doesn't really matter what platform they're on. That tends to be that surgeon or the culture of your program. But I agree that it's a different shift in how we're turning that over.
Dr. Brazel, President Brazel.
Karen Brazel from OHSU. I have a question that is something that we haven't talked about. I had one resident in Milwaukee who had to have an emergent C5, C6 procedure because of neurologic deficits. Everything came back. And I have 2 trainees now that have graduated from OHSU, young women significantly younger than I am, who have had to have emergent procedures because of neurologic deficits. And from what I understand, and I am like Carlos, I do not operate with the robots. But from what I understand, it is an ergonomically, particularly for smaller women, it is a much more ergonomically safe and advantageous way to do cases. And I do wonder, the new Society for Surgical Ergonomics that was founded by Gita Law, I wonder if we need to incorporate questions about the safety, our safety in what we offer our patients as we think about the use of the robot, because it's here. We just have to figure out how best to do it. I think the question about how it's regulated and what, those are questions. It is here. We need to figure this out. But I do think our safety and the long-term practice viability for our trainees is an important question.
Dr. Tofik actually sent me some notes on what she was going to discuss. And one of the things she brought up is being patient centric, like every single patient, the decision to use the robot or not, or open or lap. But we also hardly ever think of surgeon centric, like what's right for the surgeon. And that's what's always, we're always secondary, and we always put our patients first. But I think that's another concept that I think is not really being explored or discussed. There's a lot more attention to it, but I think that that's important, is being surgeon centric as much as you are patient centric to allow the best outcomes. Dr. Ponson.
Yeah, I think that's a great point that Dr. Braza brought up. I just think of one of my former program directors, a colorectal surgeon who did most of his cases open, then end up with a significant neurologic problems, and now does 100% of his cases with a robot, and that worked out perfect for him. So unlike Dr. Nelson here, I really think that the robot should be incorporated as part of the residence education. But I agree with him that I don't think this is the time to actually mandate it by the American Board of Surgery. So ergonomics is actually really important, and it is, especially as you grow older in this profession in surgery. The more you quickly adapt into doing that, maybe at the end of your career, that might be the best way for you to operate.
Dr. Newmeyer.
Hi, Lee Newmeyer from Jacksonville, Florida. Thanks you guys for this great panel, and I wish Sharon would have been here to add to it. I have two very specific questions. So I have to look at things from the system issue, and I'm in a system where we do a lot of cases, and there's two robots, soon to get a third, except nobody's willing to write the check for that yet, even though it was top on the equipment list. So access to the robot is not, we can't, if we use this, we got to do everything on the robot, we wouldn't get any cases done, because there's not enough robots to go around, and they're still very expensive. And so I'm trying to balance that. And yet I'm also trying to figure out, I've got to train a surgeon for when they go out, and all the hospitals around us have 8 robots. So maybe they will get to do a lot, but I think from the system level, just because we can, and I can't find a study for inguinal hernia or ventral hernia that says it's better for the patient, or it's better in any way. It's not cheaper. If anything, it's equivalent from the paper that was presented here. And as we did, I think we debated this in Napa, that the robot makes an okay laparoscopic surgeon better, but it doesn't necessarily make a great laparoscopic surgeon better. So just your comments. I don't have enough robots to go around, so we're just never going to be able to provide that level of training.
Yeah, but like you said, it's here to stay. I think it's going, and it's going to continue to go. So just to be clear, I think that there should be curriculum for residents on the robot. I just don't think that it needs to be done at the American Board of Surgery level in terms of specifying what that curriculum is. And until we know there's enough robots to go around and everyone to do it, a place like the ACGME can't require programs to do it, because there just may be good programs that, for the reasons you said, it's just going to prevent being able to train surgeons. So until everyone's equal, it doesn't make sense to mandate things.
And the other thing that's changing from the robot is the ergonomics of laparoscopic equipment. People are actually paying attention. There's these really unique new laparoscopic, handles where you can be fully 360 by rotating your wrist, and it kind of falls. So there's definitely pushing the technology. I just want to keep questions.
Brian Smith from Irvine. Thanks for putting this panel together. Really a fantastic talk and timely. The elephant in the room is that if this were any other technology that is slower, more expensive, and no better, we would probably be looking at it with much more discerning eyes. So it's important that we're having this conversation. I agree it's here to stay, but we're ignoring the fact that we're treating this different than any other technology that comes along and takes longer and costs more money and doesn't show an improved patient outcome. And I would challenge anybody that says patients are demanding this. This is not, there may be a few patients here and there, but this is not a mass demand on patient part. So there's only so much time in the day. And we really can't, as program directors, train residents how to be competent in open laparoscopy and robotics in pretty much every defined category. So Dr. Nelson, if you're not ready to make the proclamation that the ABS and the ACGME should move in this direction, would it be reasonable to consider having defined categories where residents need to be competent in open and minimally invasive approach? And perhaps that incorporates robotic and laparoscopy, but we really don't have any mandates for laparoscopy in a defined category manner currently. And so program directors could actually use those mandates to help us go out and find the opportunities, whether it be inside or outside of our institutions, to get the experiences that our residents need to make sure that they're competent for both open and minimally invasive.
Yeah. Oh, you got it. I think that you bring up a great point. I think I have a couple of surgeons on faculty that are really selective about, what Dr. Tofai said, are really selective about, they do some cases open, some laparoscopic, some robotic. But I think making the residents or having the programs document the residents does this many open, this many laparoscopic, specifically for inguinal hernias, I think is the perfect example, right? You don't want to graduate a resident. There was a discussion at this meeting last year. Somebody stood up and said their program only do robotic hernias. That's it. No open, no laparoscopic. I mean, that was shocking to me to graduate a general surgery resident. So he or she has their 85 hernias and none are open. That would be a disservice to that surgeon and to that community where that surgeon is going to practice. So I think that's a great point, a great idea to say of these 85 hernias, a third or a half have to be open and then the rest minimally invasive. And you can do laparoscopic or robotic, however you like. That would be a great component to add to that. It's a great point.
And then you get into the complexities, how you train that though, right? If you're not doing at your center 30 open hernias a year, where are you going to get that training? I think that's the next panel. I don't think we have time for it on today, but I mean, that's the future, right?
But that's where you need surgeons that are selective about it, right? We've got some zealots. I'm doing everything laparoscopic. The robot is stupid. And others that say the robot's the only way to do it. Laparoscopy is stupid. You need people that there's a role for open, laparoscopic, robotic in the same disease and the same surgeon.
Sure. Just to be respectful of time, Dr. Lucas.
I'm too damn old to become a robotic surgeon. So I have no money in the game. Clearly, by the year 2032, the vast majority of operations are going to be done robotically. All of the crediting organizations have to mandate that the program directors involve robotic surgery, which would increase each year by a certain percent. I don't want to hear about how difficult it is to teach. The four of you were incompetent at one time until people my age taught you how to tie a knot, how to open an abdomen, and how to recognize deep structures within the pelvis. In the year 2042, we don't want two classes of surgeon in America. We want America to be a country where people are even and everybody knows how to do robotic surgery. So go do it.
My name is Mark Telemonte. I'm from Evanston and North Shore Health System in Chicago, and I really appreciated the presentation. I commend the program committee for putting it on. I think there were some critical points that perhaps were understated. And I say that only because 6 years ago, we embarked on a program to advance complex robotic surgery at our institution. I went out and learned how to do it from Melissa Hogan, who wrote, I think, a sentinel paper. And the title of that paper was See One, Do One, Teach One, No Longer the Right Surgical Paradigm for Robotics. And I think that changed the way that we approached it, the way I learned it. And so my question for you, for ACGME and the American Board of Surgery is, I think you're right. I think it's not going to happen where you say we have to graduate every general surgery chief resident with 25 or 30 robotic surgical cases. But what I think is crucial, and we've got many of the University of Chicago residents here who embark on a 2-week structured curriculum with measured skill acquisitions in their third year of their residency program. And I think having some formal training in exactly how difficult it is to learn how to suture with the robot. We make it sound like the robot's an enabling technology. And if you can't suture laparoscopically, you're going to be able to learn how to do it robotically more easily. I don't think that's true. So I'm interested in your perspective on if we forget the case numbers and just focus on every general surgery resident should graduate with some experience, with some formal training in a structured curriculum with skills acquisition. I think that if you ask the University of Chicago residents that are here with us today, they'll tell you they learn more respect for what not to do with the robot because it's such a hard thing to really master. And then they go and do their residency and they do a 13-minute open lap chole for routine cholecystitis. And they're like, I don't need the robot for that. But when I do want to do the robot for a distal pancreatectomy, they do so with caution and appreciation for how difficult it actually is to learn how to be masterful with that, not what the intuitive rep tells you. So I'm just curious about that because I really thought your perspective from the ABS and the HGGME was right on target, but the curriculum part, I wonder what you think about that.
Yeah, and let me be clear is understanding robotic principles is a requirement of the curriculum. And I think that in my program, we have a robotic curriculum. I think it's actually crucial. The question I'm answering is who should create that curriculum and who should enforce it. And I don't think right now that is a good space for the ABS to go into, but it could change. I mean, it could change. I'm giving you my opinion. I'm not saying, but our official paper says it's an enabling technology. So I think that's kind of where we're at with it there. But
it's almost past 3 p.m. Yeah, for the break. We still have
UC
time.
Davis. I think the most important thing is that we should stay the course and do not accept robotic surgery as a subspecialty or whatever it is. It is a computerized instrumentation that's available for us to use. So it's just another technology. So regarding the question whether or not you should, how you to maintain the open surgical skill, well, haven't we debated enough of that since the beginning of laparoscopic surgery? And we never have come up with how to do that. It's naturally gonna maintain if you know how to do it. So I would say that let the technology develop itself. Our job is to make sure that the resident have a wealthy balance between open, laparoscopic, and robotic. So I do robotic most of the time, more than 50%. But when it comes down to procedure that I can do laparoscopic, open, or robotic, my resident can never figure out why. And every time I do a case, I ask them, why do I do this case open? And why do I do this case robotic? That's how I think you should train them.
That's exactly what Dr. Tofik said also in her notes was every time she does a case with a resident, she spends time explaining why she chose one modality over the other rather than going through any one of them. I do think that, we continue to learn and evolve. I think shared paradigm training is going to be the future to be able to maintain these things. But I'll go back to what Dr. Neumeier said on the system level. My surgeons is trauma, emergency surgeons, middle of the night. We're not getting the robot docked at 2 a.m. They're never going to give it to us. How do you maintain our groups to stay focused and forward with the robot, like Dr. Luke's mentioned? But either way, I just want to thank the panelists for an amazing session and thanks everyone for being here to support. Yeah, there's a break until 3:20. Sorry, there's a break until 3:20. We're gonna actually.